Hey gang, welcome back to the channel. New lit just dropped, so it's time for a rapid response. Today we're talking about the COBRRA trial, or bleeding risk with apixaban versus rivaroxaban in acute venous thromboembolism. It was a randomized trial that placed patients with new VTE to either receive apixaban or rivaroxaban at typical doses. There was no industry sponsor, and this was led by the Ottawa Hospital Research Institute. The primary outcome was clinically relevant bleeding, which was a composite of major bleeding or clinically relevant non-major bleeding, as defined by ISTH. We already have some information on this comparison from Ray and colleagues published in JAMA, which compared rivaroxaban and apixaban for atrial fibrillation in a large cohort of 581,000 patients. The primary outcome in this study was a composite of major ischemic and hemorrhagic events, which was significantly better with apixaban, as seen in Figure 2 here. Results were driven by both ischemic and hemorrhagic events. Most of these results were comparable for both standard and reduced doses of anticoagulants, although ischemic events were similar in those that received standard doses. Additionally, patients receiving apixaban had a lower risk of mortality when given the standard dose. While interesting, the results of that trial were not from an RCT, and questions still remain about the indication of VTE. Loading doses are much higher and may contribute to a higher risk of bleeding, so still a question that needs to be answered. The COBRRA trial assessed outcomes at a 3-month time period, the minimum amount of time that you would anticoagulate a patient after a new VTE, which was relatively reasonable. To attempt to control for any confounding, patients were stratified by a creatinine clearance less than or greater than 50, ongoing antiplatelet use, and the center that was randomizing them. In this trial, there was no blinding. Patients were able to pick up prescriptions from their community pharmacy. Key exclusion criteria included weight greater than 120 kilos, following ISTH guidance from the time the study was incepted, a cancer diagnosis, or liver disease, so Child-Pugh Class B or C. The trial was designed to achieve 80% power and detect a 33% reduction in the primary outcome, which was the minimum clinically meaningful reduction as determined by the study design. The authors assumed a primary outcome event rate of 5.4% for patients in the apixaban group and 8.1% for those in the rivaroxaban group. While 8.1% matched rivaroxaban's rate in the Einstein trial, it was unclear why 5.4% was selected for apixaban. For comparison, the rate of the primary outcome in Amplify was 4.3%. The authors determined they would need 1,352 patients in each group, assuming 2% loss to follow-up, so they aimed for around 1,380 for both groups. The authors were able to randomize 1,345 patients to apixaban and 1,355 to rivaroxaban, mostly from Canada. Most patients in the trial had an unprovoked VTE event. 52.2% of them had a DVT, and the remaining 47.8% had a PE with or without DVT. Only 15.9% had a VTE history prior to the trial. In the intention to treat analysis of the trial, primary outcome occurred in 3.3% of apixaban patients and 7.1% of rivaroxaban, which was a statistically significant difference. Seen here in the supplement, these results were consistent across most of the subgroups, with some notable exceptions. There was no difference in those with a history of VTE, but again, this was only 15.9% of the total trial. Some various sites of clinically relevant non-major bleeding were noted in the trial. Vaginal bleeding was the most common form in both groups, although it was somewhat higher in the rivaroxaban group. Also noted were gastrointestinal bleeding and hematuria. Taking a look at Figure 2, which includes clinically relevant bleeding, there was an immediate separation, with rivaroxaban at a higher rate than apixaban, which was maintained throughout all 3 months of the trial. This raises an interesting question. Is the rivaroxaban loading dose too aggressive? It's around 50% higher for a longer duration than apixaban. One study that attempted to answer this question was a comparison of apixaban and rivaroxaban with either a mixed lead-in or full lead-in doses given. In this study, giving a mixed lead-in regimen did not lead to a lower risk of bleeding in comparison to patients that received full lead-in with either apixaban or rivaroxaban. Taking a look at Figure 3, can note that there's no difference in recurrent VTE throughout any of the time period in the 3-month trial. Looking at these results brings us to an important question of adherence. In this trial, adherence was assessed by asking all of the included patients 3 different questions. Did they take all of their medication? Did they skip any doses? And were they not able to take all of their medication? For patients to be considered to have complete adherence, they needed to answer correctly to all 3 questions. The result of this assessment was that patients in the apixaban group had complete adherence 65.7% of the time versus 75.1% of the time for patients that received rivaroxaban. This result is not entirely surprising. A 2025 British Journal of Pharmacy article from Quiros Lopez and colleagues compared adherence with DOACs. Around 35% of the studies compared favored Rivaroxaban for better adherence over apixaban. However, 45% showed no difference, and around 20% favored apixaban, so differences in adherence may be overall negligible. A better way of assessing adherence for this trial may have been following in the footsteps of Amplify, which looked for around 80% adherence as a threshold instead of overly focusing on a single dose. Like assessing a time in the therapeutic range with a patient on warfarin, we shouldn't expect perfection with anticoagulants. People will occasionally miss doses. Complete adherence may not be as useful as a patient that receives almost all of their doses. Also of interest, the ongoing COBRRA-AF trial is assessing clinically relevant bleeding at 12 months in patients with atrial fibrillation instead. Results of that trial will also be very helpful in determining how safe it is to continue using apixaban or Rivaroxaban for atrial fibrillation. So, what do you think? Is Rivaroxaban still a first-line agent for VTE? Or should we rethink our choice in patients that are able to choose between these two agents? Is it still reasonable to give Rivaroxaban in the right patient? I'm a little hesitant to recommend Xarelto in some patients, but don't take my word for it. Read the studies linked in the description and decide for yourself.